Today we are going to talk about the defects of inflammation. In first two lectures we talk about the types of granuloma and introduction to the inflammation. Today we will talk about some defects in inflammation. So before going through the main topic, you must need to have some idea about the cellular changes that we can see in case of inflammation. So what does mean the cellular changes? That whenever there will be inflammation anywhere, there will be migration of the neutrophils or the WBCs to that side of inflammation. For example, if inflammation is going on here, then definitely the neutrophil they reach to the side of inflammation. As we know that the neutrophils, they are the intravascular, they're present in the blood vessel, so they need to go to the site, and this process is what we call as the cellular changes. It may be intravascular cellular changes and extravascular cellular changes. So I will give a brief idea about the changes in a sequence. That is, initially, whenever there will be inflammation at the site, for example, these microbes enters into your body, the local macrophages try to engulf, and they release different sort of cytokines, as well as the mast cells. They also release histamine. They causes vasodilation, increasing permeability. So because of changes in the permeability in the vessel, the space between the endothelial cells, the vasodilation effect, that can cause extravasation of the fluid to the side of inflammation. So there will be exudation. Because of that, the blood become little bit hemoconcentrated. There will be vasodilation and stasis. So because of that, the neutrophil, they start to come toward the periphery, and this is what we call as margination or pigmenting. This margination brings neutrophil closer to the endothelial cells, and on the endothelial cells we have different types of receptors like P selectin, E selectin, and on the neutrophil we have also glycoprotein receptors called as Cli-Lewis X modified glycoprotein. Whenever these two come in interaction with each other, then there will be formation of bonding, but this bonding is not as that much strong. So the blood flow will break this bond, and now neutrophil will go to the another endothelial cell, and this process is called as rolling, because neutrophil roll from one cell to another, one side to another side, one endothelial cell to another endothelial cell. After some time, there is a formation of bonding between the IKM, intracellular adhesion molecule 1, with the receptor present on the neutrophil, that is the integrin. So this is what we call as the orange one is the integrin. So they also said here that this one is the integrin, high affinity state integrin. So this high affinity state integrin make a bonding between ICAM or IKM1, and this bonding is strong than that of this bonding, which is formed between the selectin and the Cli-Lewis. So because of this bond, there will be adhesion, a tight junction, a tight bonding will form. So this one is what we call as the tight bonding or adhesion. After that, there will be diapedesis or transmigration. It's not only migration, it's a transmigration. So transmigration or diapedesis, where P came on endothelial cell and P came on the neutrophil, they will make a bonding, and then there will be entry of neutrophil from the vessel to the side of inflammation or extracellularly. After that, these chemotactic agent they will attract the neutrophil, and neutrophil will start to move toward the side where there are a lot of bacteria or microbes. This is what we call as the chemotaxis. So these are the steps. So if there is any defect in any stage here, then we will consider that is as a defect in the inflammation. Other defects also there, but two important defects, they are related to the receptors. So let's see what are the defects that are associated with these molecules. There is the lead 1 and lead 2 defects. So leukocyte adhesion defect 1. The leukocyte adhesion defect, these are the rare genetical disorders. LAD1 is caused by the mutation in ITGB2 gene, which leads to deficiency of beta 2 integrin. So it's an integrin defect. So what integrin were doing? Integrins, they were helping in making a bonding between the receptor present on the endothelial cell, that is the I came. So once the I came and the integrin, they interact with each other, then there will be a formation of tight bound, and that is what we call as the adhesion, a strong adhesion. So if there is integrin defect, so there will be no adhesion. So it's also an adhesion defect. So a molecule required for the leukocyte migration, that is the adhesion defect. From the blood vessels to the site of inflammation. So maybe you understood that whenever there will be lead 1 means it's similar to that of I, so you can remember like this: 1 integrin, okay, integrin, and integrin help in the formation of adhesion. So if there is defect to integrin, there will be defect to adhesion, so there will be no migration of the neutrophil. What will be the sign and symptoms? Severely affected infants have recurrent or progressive necrotic soft tissue infections with staphylococcal or gram-negative bacteria, periodontitis, poor wound healing, no pus formation, because for the pus formation, the neutrophils should be there. Without neutrophil, there will be no pus formation. And leukocytosis, because infection is going on, the bone marrow getting stimulus to produce a lot of cells. That's why there will be leukocytosis. And delayed umbilical cord detachment is a main point you need to remember as far as the lead 1 is concerned. If you have any question, and if they give like delay umbilical cord detachment, you must think about the lead 1. Another one is the lead 2. So what defect can we see in lead 2? So in case of leukocyte adhesion defect 2, there is a mutation of a SLC35C1 gene, which leads to deficiency of CLI Lewis X. What was the location of CLI Lewis? CLI Lewis glycoprotein receptors, they are present on the leukocyte, which were responsible for making a bonding between selectin molecules that helps in rolling. So it's a rolling defect. So which leads to deficiency of CLI Lewis X glycoprotein on the leukocyte surface, which helps in making a bonding with the endothelial surface molecule called selectin during the rolling. So it's a rolling defect. So what are the signs and symptoms? Recurrent infections, persistent leukocytosis, severe mental retardation and growth retardation, and Bombay phenotype blood, which is H antigen on the RBCs, and it's a very rare type of blood. So if they give like Bombay phenotype blood, you need to remember or think about the lead 2. There is another one, that is the lead 3. So it's a genetical defect in lead 3, is a mutation in a gene candlin 3. It's a protein essential for all integrin activations. So this was about the lead 2. Another is the Chediak-Higashi syndrome. So I will give some hint or some introduction before going through this disease. So you know that whenever there will be phagocytosis, the leukocytes engulf the bacteria, they form the phagosome, and lysosome is already present inside. So this phagosome and lysosome, there will be fusion between these two. After the fusion, this lysosome destroy the bacteria. So if there is a defect in the movement of lysosome, so then there will be no formation of phagosome. There will be no fusion between the phagosome and the lysosome, so there will be no formation of phagolysosome. So because there will be no formation, it means the bacteria start to grow inside the cell. So if there is defect, that defect is called as the Chediak-Higashi syndrome. So Chediak-Higashi syndrome, the Chediak-Higashi syndrome is caused by the mutation in the LIST gene. This gene provides instruction for making a protein known as lysosomal trafficking regulator. This lysosomal trafficking regulator is responsible for the movement of lysosome toward the phagosome, which helps in the formation of phagolysosome. So LIST gene defect leads to defective phagosome formation and defective degranulation of WBCs. In addition, there will be defective degranulation of platelets and defective degranulation of the melanosomes. So melanosomes, these are the vesicles having melanin inside. So when these vesicles, they also fails to move to the surface of the skin, then there will be no discoloration, no darkening of the skin. So that can lead to albinism. And platelet degranulation defects, it cause lack of formation of thrombus, then that can lead to bleeding manifestations. So defective degranulation of WBCs and failure in the formation of phagolysosome leads to recurrent infections. Defective degranulation of platelets leads to bleeding, and defective degranulation of melanosomes leads to albinism. You can see that this is what the defective melanosome movement or degranulation that leads to albinism. Here we can see giant large granules inside the neutrophil, and this one is the recurrent multiple or recurrent skin infections. Chronic granulomatous disease, some idea about this. For example, there are different pathways by which the WBCs, they kill the bacteria. Number first is the oxygen independent pathway by different sort of enzymatic activities. Another one is oxygen dependent pathway. In this, oxygen should be there, and another enzyme should be there like NADPH oxidase. This NADPH oxidase utilizes oxygen, and hence formation of reactive oxygen species, and this reactive oxygen species then now kill the bacteria, and all this process happen inside the neutrophil. If this pathway is defective, then there will be no killing of bacteria inside the neutrophil. So there will be giant granules with bacteria start to form. So what this is statement is saying, a chronic granulomatous disease is a genetic disease. In CGD, a mutation in the FOX gene causes a defect in an enzyme called as phagocyte NADPH oxidase. Certain WBC cells use this enzyme to produce hydrogen peroxide, which is a reactive oxygen species, which these cells need in order to kill certain bacteria and fungi by oxygen dependent killing. So if there is defect in the FOX gene, defect in NADPH oxidase, defective respiratory burst or oxygen burst leads to granuloma formation inside the cell. Small granules start to develop or form. So symptoms, a recurrent infection occurs mainly by catalase positive bacteria. So the diagnosis of the chronic granulomatous disease, that is we use spatial dye, that is nitroblue tetrazolium chloride test. So this one is a colorless dye. Whenever you put this dye on the WBCs, this dye change into blue color if there is oxygen dependent pathway is there. If the oxygen dependent pathway is not working, then the neutrophil unable to use the dye, so there will be no change in color. So if you see here, so there will be the NBT test is a negative in X-linked type of CGD. NBT dye is not converted to a blue dye because of NADPH oxidase enzyme complex deficiency. Normally there will be a normally the NBT dye which tends to blue if superoxide free radical are present, like hydrogen peroxide or some other reactive oxygen species or free radicals they are forming as a result of oxygen dependent pathway. That free radical convert the tetranitro blue tetrazolium chloride into blue color. If there is colorless, it means that this pathway is defective. So that was about the defects. Thank you very much.